told you that within 24 hours, the possibility of curbing complications, transmission, and all the like that is leading to mortality is high. The worst was with the guardian. And we found out that 0 out of 2, that is 0%, came within 24 hours. So it means whoever was under their care progressed to complication and the possibility that there was mortality. When we came to caregiver's age, this one, the relation was not that complex, but there was progression in the as the mother grew up. There was a progression of what? Of neglect. Not really neglect, but maybe they developed false confidence that after all, I had the other child suffering from the same condition and they recovered. So maybe we need more sensitization, especially in this area. And we have recommended further study within the age and the relationship with attention seeking or like seeking for attention, as the else-seeking behavior. On top of that, we looked at caregivers' education level. Here it is, you can check on that green strip. It is showing us that 5 out of the 6 that he brought the children, they were in position to come early. If you fold that column, which shows yes, yes, all these ones that are showing yes, it means they came within 24 hours to seek for the health care. On that part, there is even a caregiver's occupation, whereby, I'm sorry, there is something down, but it can't, I think it can't, but I will talk about it. You take me back to the main slide. On the main slide, we see that the worst was with self-employed caregivers. And probably these ones were so into their work. As you know, when you are self-employed or any venture is always targeting profits. And the more the owner of the venture you are there, the more you make profits. So in most cases, they leave these children with the guardians. And yet the guardians up there we're seeing that 0 out of the 2 that were guardians of our children came within 24 hours. What does it mean? The mothers will still remain the mothers, and if we are to curb this, we have to liaise and sensitize and ensure that mothers are there with their children always. On behalf of those that are supposed to give the care, that is on our behalf, yes. We are saying that we're talking about attention. 2 areas we focused on the caregivers. We focused on the age of the child, and then we also looked at the area of residence. Please take me to that where there is poor. Okay, thank you for that note. Here we focused on whether they are always attended to. When the child is brought, we are talking about bringing within 24 hours. But what if they brought and no one was there to care for them? And we saw that mostly we are caring for those 0 to 6. I know very many will say that is part of the red flags, like whoever is 0 to 6 is recommended to be cared for first in the clinical practice. But as we said, what comes next after the 24? Within 24 hours, within 48 hours of infection of malaria, we expect that complications will set in. Why? Because we have multiplication. And we said no matter the age, we shall get the same complications which are now leading to mortality. Why don't we channel all our, channel our attention and we do it equitably? Like where there is a need, not only following the red flags. Because if you care for me today when I'm 0 to 6 months, and tomorrow you lower your attention, if I die, it means what you did at 0 to 6 months is useless. On residence, Professor Clear yesterday was also telling you that in Uganda, 80%, which is actually common in most of these sub-Saharan African countries, that 80% of the medical workers, they reside in urban areas. And 85% of the conditions that they are supposed to work on are in the villages or the rural areas. And here we are seeing that if we can compare, 4 out of 14 did not come. That is in urban. But here, 15 out of the 36 that reside in rural areas did not come. And we are seeing from the World Malaria Report that these people are either going to where? They are either going to the traditional eras, or they are just home waiting for what to come next. Why? Take me to the main slide and go to the second. These are some of the probable reasons we found out. Yes, you may tell me 50% is already coming by the means of a motorcycle. But even affording a motorcycle for some of these people within the rural areas is something very hard. And on top of that, a considerable number, if you can see there, 26% is not something easy. Even 1%, you may think it's small, but be part of it, my dear, you'll tell me. These mothers or the caregivers are not coming because most of them are footing. So what if instead of waiting for this mother to come either by a motorcycle, a vehicle, or whatever they may afford, what if we go and look for that patient? After all, in Kenya, they have the RTSS, the vaccination, which can be used before even the mother or anyone gets the issue, and it is addressed there and then, and it is conferring some immunity before these people come to their own immunity. Please take me next to. Okay, I think she can just take us through the.
Okay, maybe just because of time, I'll rush over it. Factors influencing high prevalence, that is number one, caregiver relationship to the child, as he has already explained. I don't have to go through it again. The child age, as he has already shared with you. Reduced attention, neglect, low levels of income continue to influence the burden, low levels of education, age-specific attention, discriminative health care, inequity in service delivery, lack of evidence-based care. So all this actually is what he has shared with you through the slides, and it's like summary of whatever we have presented to you.
Next. As we conclude, these are some of the recommendations we would love. Mr. MC, we are finishing. Community health should be emphasized. The COs, we are trained to go to easily to go to the rural areas. And if you can check, you may find that 80%, or you will find that 80% of the NGO workers in villages and whoever is sensitizing the community is a CO. So if we can advocate for COs and that part of community health that they are trained to do, we shall really curb many of these conditions, and we shall have the universal health coverage.
Okay.
Yes, I'm finishing. So, better services should be extended to rural areas for timely health service delivery. And on top of this, I will majorly talk about the sensitization and the evidence-based service delivery. You find that most of the COs and the health workers, when they attain their certificate and then they get a job, they tend to concentrate on it. But every day, the diseases are modifying themselves so that they fit better in the community. For us, if we are just stable there, doing nothing about it, what do you think is coming next? On top of the resistance, you even phase out yourself when you cannot manage a condition that you previously managed well. Some of the conditions and the drugs that we use in management, for example, this well malaria, there was quinine and so many other drugs that were being used initially. But you see that they are phased out. So if you were trained some time back, even though they are still being used, but there are some better interventions in different conditions of malaria. So we have to get acquainted with what is coming next by acquiring better positions to curb this what? Condition, not only malaria. I will also inform you that there is a malaria conference here in Kigali again. I'm from Uganda. But in Kigali, we have a malaria conference. So for those who are interested in malaria and neglected tropical diseases, you are welcome in June.
Thank you. Put your hands together for him. Yes. Thank you very much, Dr. Alex, and then Miss Narsibo, Sarbo, the last one. Okay. Marsa. Please put your hands together for them again. Yes, you can please take your seat now. Thank you very much for that excellent presentation on malaria. Now, we move on to the next agenda, and this is a presentation coming all the way from Malaysia. It's a 10-minute presentation on the services. Is it what? It's a presentation on the services of medical assistance in Malaysia. And it will be done by Mr. Wilson. Mr. Wilson. Yes, the last one, I won't try. Yes. So, Mr. Wilson. Okay, so as he sorts it out, how many of you here are from Rwanda? Please put up your hands and let me see. If you are from Rwanda, put up your hands and let me see. If you are from Rwanda, put up your hands and let me see. Yes. We want to appreciate our host nation. Please be on your feet so we appreciate you. Can you please be on your feet so we appreciate you right now? Can you please stand up so we appreciate you? Yes. Please, please, let's put our hands together for our host nation. I mean, they've hosted us very, very nicely. We thank you all very much. Can you please take your seat now? Thank you all very much. Mr. Wilson, the stage is yours. We are ready when you are.
Thank you, sir. And
You're
my
welcome.
time is 30 minutes, not 10 minutes.
Don't worry.
You got to be fair.
We'll work with that.
Right,
We'll
okay.
work with that.
Right. Selamat petang. Selamat datang. Salam Malaysia. You want to follow me? Selamat datang. Selamat petang. Once again, selamat datang. Selamat petang. Okay, that is to wake you up from your slumber. Right? Okay? Right, ladies and gentlemen, my name is Wilson and I come from Malaysia. I just greeted you in my national language, the Malay language. You just wished yourself welcome. Good evening and greetings from Malaysia. Right? Now, every other person that I greet and I meet since yesterday has been telling me, I'm coming to Malaysia. I'm coming to Malaysia. So that's why I've started practicing you on the greetings in Malaysia. Okay? And in my presentation today, if you see, okay, I've added some pictures here. So from this deep interest to come to Malaysia, I'm going to fan it and turn it into a burning desire to come to Malaysia. So it's going to be a dual purpose for me, right? So my main topic will be services of medical assistance in Malaysia, and an indirect purpose will be to promote Malaysia, right? Just to keep you awake, right? Now, first of all, who am I? I'm a certified medical assistant. When I studied, we were still known as medical assistant, and we were given a certificate, even though it's a 3-year program. Then, subsequently, the certificate was upgraded to diploma. And my supervisor who supervised me to be upgraded to diploma is Cikgu means teacher, my teacher. Okay, Cikgu Muhyiddin Hassan is here. He's the one. Okay, and then I went on to university to do a degree in biomedical science. So my background, I spent 10 years in the hospitals, working in emergency departments mostly, and another 10 years I spent in primary health care. Okay, and 5 years I was the manager of Clinical Research Center, where I was supposed to facilitate and promote clinical trials. Okay? Now, why I'm saying this? Because from that you can gather the functions of medical assistants, not related to just clinical work alone, right? And then, for the last 5 years, I've been the Chief Assistant Medical Officer for the state of Selangor. Okay, my presentation will be a brief history of the profession, laws governing the profession, role of the Medical Assistant Board, scope of services, area of services, and the way forward. So it will be very, very brief and simple. Okay, now for those of you who are not familiar with Malaysia, don't look at the pretty girls here, see here. All right, I come from here, Selangor. Malaysia is made up of 15 states, including 2 states in the island of Borneo, and this is where I come from, Selangor, the most populous and the most developed state in the Peninsular Malaysia. And for those who are coming next week to Malaysia, you will be coming here, the island of Penang. It is known as the Pearl of Orient, not today, yesterday, for centuries, and it is a Pearl of Orient. All right, a very, very much sought after tourist spot. So please do come to Malaysia. You will be fascinated. All right, clap for that. Okay, and for those who still do not know where Malaysia is, this is where we are. Right? Some people think I come from Kenya. Okay, but I'm from here, Malaysia. Right, a brief history of the medical assistant. After this, Tuan Haji Mustafa will be elaborating deeply into this. This is one of the earliest profession in the Malaysian healthcare system. All right, at one time, and it is still is the backbone. The medical assistants are the backbone of the Malaysian healthcare system. It was introduced by our colonial masters, the British government. Okay, and we were the substitute of doctors in the beginning of this entire healthcare. The name of the profession changed according to the role. So initially, when we started in, when it was started in 1786, we were known as apothecary. Then in 1950s, we were known as dresser. You know why? The primary job at that time was doing dressing for surgical wounds and all other type of wounds. So we are known as dresser. Even till today, we are called as dresser. Okay, dresser. We are happy about it. Okay. Then in 1960s, we were known as Pembantu Rumah Sakit. I cannot translate this because it is almost same as this: hospital assistant, medical assistant, and assistant medical officer. Now, all these names actually reflect the role, the scope of services that we were doing. And if you look at it from hospital assistant, which means we were assistants in the hospital, doing all kind of jobs in the hospital. Then slowly we become medical assistant, now assistant to medical officer. All right, now in 1977, okay, an Act 180 was passed in the parliament. It was gazetted in 10th March of 1977. This gave us the legal legitimacy for our existence. So our profession comes under this Act of Laws of Malaysia. It was gazetted on the 10th of March 1977, and so 10th of March is celebrated as the National Day for Medical Assistance in our country. So this year it falls on a Tuesday, so we move it further to the 14th so that you all can come on a weekend. Not you all, some of you are coming. Okay? Right. So we exist under this Act. Okay? Now, what does this Act say? There are 5 sections in the Act. One is the preliminary part. Second will be the establishment of the Medical Assistance Registration Board. Third will be Register of Medical Assistants, entitlement to registration and registration. Part 4 will be publication, removal and restoration. Part 4 will be appeals. Part 6 will be general. Okay, now basically this medical